welcome to our latest edition of our Facebook Live series. My name is Jennifer Williams, your host for today, and we are sitting down with two of our excellent physicians, Dr. Edward Gray, Chief of the Division of Critical Care Medicine here at Cooperman Barnabas Medical Center, and we're welcoming back Dr. Fariborz Rezai, Director of Critical Care Medicine for RWJBarnabas Health. We'll be discussing everything you need to know if you or a loved one is admitted to the intensive care unit, the important role our team plays in the continuum of care to keeping our patients safe, and so much more. So if you have a question for either Dr. Gray or Dr. Rezai, we want you to leave us a comment below, and please help me welcome Dr. Gray, Dr. Rezai. Hi.
Hello.
So nice to have you both here.
Good to be here.
This is exciting for me. We've never done a critical care medicine Facebook Live, so I'm excited to learn more myself and to educate our viewers some more. So thanks for being here.
Sure, long overdue.
Yeah, so let's start off simple and just tell us a bit, Dr. Gray, the work you do at Cooperman Barnabas Medical Center, and Dr. Rezai, the work that you do for our system.
Sure. Well, I'm the medical director and chief of the ICU service here at Cooperman Barnabas, which means I run the ICU along with a very large team made up of other physicians. We're specially trained in medicine and critical care medicine, so it's an extensive training process. And we take care of the sickest patients here in the hospital. Our patients are made up of those who come to us because of a level of care, a level that they need because of how ill they are. And it's a very special place because of that. It's segregated not along the lines of organ dysfunction, like I had a heart attack, or my intestine is bleeding, or my kidneys have failed, but it's a level of sickness. So generally multiple organs are in trouble.
And can I ask you why you chose to get into critical care medicine, and what really kind of drove you to that? Because it's so important. It's such an important job that covers so many different aspects of care.
Yeah. Unfortunately, I had a lot of experience at an early age with a lot of illness in my immediate family, and that's where I got exposed to ICU in the first place. And it was something I was absolutely fascinated with when I first saw it, and I've never lost that fascination. So that's really what drives me, and the work we do is very fulfilling, very rewarding, and that's what keeps on driving me.
Yeah, so important. Dr. Rezai?
Yeah, so about 2.5 years ago, I moved into the role as System Director for Critical Care. Prior to that, I was 10 years as a director at ICU here, but I've been here for a long time.
Yeah.
I don't want to count. I started at the age of 2. But my role really, as of being in this system role, is really to make sure that our clinical and operational critical care services throughout the system at all 12 hospitals are standardized. To make sure that we can deliver the same level of care at all sites, Community Medical Center, New Brunswick, at Cooperman, that we expect. So again, it's been a great task, and it's been going really well. I'm enjoying it a lot because it's been such a success, and I really have really enjoyed it a lot.
Yeah, and what drove you into critical care medicine?
Yeah, so critical care medicine is an interesting field in the sense that you just don't know what you're getting. My dad was a cardiologist, and I used to always joke around. Cardiologists, there's either the plumber or electrician. Like they either open up arteries or they're converting people. There's more to that than just that. So I'm not going to mock in cardiology, but my point is that with critical care, there's surgical cases, there's medical cases, there's neuro cases. When we had COVID, there was COVID cases, pneumonias, and all those things, drug overdoses. So you just don't know what you're getting. It keeps you on your toes. It really keeps you on top of your medical knowledge too, because you have to be on top of it to really deliver that care that you expect.
Yeah, which I'm sure is so exciting as a learner, a lifelong learner, and a doctor. You're always wanting to know what's next and see what's next. And so, Dr. Gray, tell us about the important role a critical care doctor does play in the hospital.
Yeah, sure. Well, as I was saying, we deal with the sickest patients, the most defenseless patients, and people who need our help more than any in the facility. We will meet patients either in the emergency department, people coming out of the operating room, people who are just in the hospital itself and then are not responding to therapy and decompensate on the medical ward. So we meet patients from every part of the hospital. And we then treat them appropriately. Again, it could be a situation with multiple organ system failures, or as Dr. Rezai was saying, an overdose, some kind of toxicity. So yeah, it's a constant learning process that never ends, as you were alluding to.
Yeah.
You're a lifelong student, and they do keep you on your toes. Prevents burnout.
Yeah.
Because you never know what's going to walk through the door next.
And it's great that you're still so passionately about it. I can tell when I talk to you.
Yeah, no, I have to credit the patients.
Yeah.
They provide unbelievable fulfillment.
Oh, that's amazing. And Dr. Rezai, you were alluding to before as well, that standardization of care in your new role. So tell us about those advancements in critical care and the closed unit concept. I know that you've had a huge role in bringing to all of our hospitals in the system.
Yeah, so one of the reasons I went to critical care was the closed unit concept. And for those of you who don't know, so closed unit is basically a board certified critical care physician like myself and Dr. Gray, who manages the patients 24/7 in the ICU. In the old days, they were called open ICUs, and the open ICU concept was patients who were sick, they would go to the intensive care unit. But your physician from the outside would come see you, call a bunch of consultants. They weren't physically there, they would go to their offices and do other things, but there was nobody physically there who had that level of training. We've come to learn over the past few decades that these patients obviously are very sick, and they require a level of training that's a little bit more advanced. So, we both went through internal medicine. You could be emergency medicine, you could be general surgery, anesthesia, but the requirement is do that fellowship in critical care and get boarded to take care of these patients, because the level of care is a little bit more intense. No pun intended. So intensive care. So I think the reason I went into this field is because that closed model concept. I did not want to work in an open ICU. I want to work in a closed ICU where we manage those patients 24/7. So it's funny because when I was finishing my fellowship at Newark Beth a number of years ago, I was actually looking out of state because New Jersey didn't have a closed model ICU, and one of my colleagues called me up and said, hey, you know what, St. Barnabas at the time is looking to close their ICU. And long story short, I became employed here, so did Dr. Gray, and I never looked back. And then from there, as I became the service line director, really bringing what we have here throughout the system, and to make sure that our closed model is standardized throughout the system, where we have protocols that we all adhere to. We also adhere to guidelines and quality of care that is to the level that we all expect.
Yeah.
It's amazing work that they're all doing each and every day. It really truly is such a blessing and a calling to have doctors like you here, and so we're so grateful to have you.
Thank you.
We're great to be here.
Yeah, and so Dr. Gray, how important, you're seeing patients at their sickest, their families it's such a difficult time for them. How important is it for you to establish communication with both the patients, their families? How do you work towards establishing that trust in sometimes such a short, period of time?
It's extremely important. Sometimes we're fortunate and patients' families are already in the hospital, or they've come with them to the emergency department, or they're in the medical ward, or they're waiting for them to have a surgery. So we can touch base almost immediately. And we also like to find out, aside from the medical history, what was it that was important to the patient? What were their goals? What were they hoping to accomplish? Get a feel of what their value systems were. And we can also sort of target care along those lines as well. It's not just the medical approach. Really, what did the patient want? How aggressive did they want to be? And frequency of contact with family, which is most important. They are contacted by telephone immediately in the morning, and then we meet with them in person once they come in to visit their loved ones.
And also encouraged to be on rounds.
That's also true. They're much more than welcome to take part in the academic rounds and the clinical rounds, which is made up of a very, very large team. We round every single day for several hours in the morning, reviewing the entire case on every single patient from start to finish, everything from the lab results to how the patient is progressing, what kind of medications they are on, what they might need, what needs to be changed. Do we need more evidence? Should we get more imaging? Is there something that's undiscovered? So the family members are more than welcome to join here. And they can ask a multitude of specialties once they're on rounds, because it's ICU doctors, it's advanced practice providers, it's nursing, it's pharmacy, it's rehabilitation teams, it's speech therapy, it's really multidisciplinary rounds is what it's called, and it really does represent many disciplines. And usually family input is very, very important to get an idea of what the patient was like. How do you tell if someone on a ventilator who's sedated? How do you tell if they're in pain? Well, family members usually can see subtle changes in expression. They're very, very helpful to add that bit of information.
Oh, wow, it's amazing. And that communication is so important.
Very.
And like, I look at critical care doctors as like the jack of all trades. You know, you have to know so many different things and really be on top of your game. So Dr. Rezai, like, you know, you're seeing patients from the emergency department, the operating room. Like, how do you manage all of that? How do you know, as a doctor, know which kind of direction you're getting pulled in? And
I think we're just built to do that. From our training, it's always been like that, and it keeps us on our toes. And I know we mentioned that before. It really does, because it doesn't get boring, because you just don't know what you're getting. And I can go from a surgical patient, I can go right to an overdose, I can go right to a neuro patient who had a stroke. You just don't know. And you just have to go in there with a complete clear mindset and say, okay, ascertain what's going on with the patient, try to get a good history from the family members that's appropriate, and try to figure out what's going on. It's almost like trying to figure out a puzzle. It's you're going in, you're trying to what do they have, what's causing all this, and it just makes it so interesting. It really does, because at the end of the day, if you can solve the puzzle, you can save a life. So
it's awesome. It probably feels like so fulfilling, and so like when you have that all the pieces align. And Dr. Gray, you were kind of talking about that multidisciplinary team. Can you tell our audience about that that's a hard word for me, continuum of care for patients? Someone is always here 24/7, and so how important is that teamwork and that communication?
Yeah, it's of paramount importance, and it's a large team, as I was mentioning. It's physicians, it's advanced practice providers. They're made up of nurse practitioners or physician assistants, pharmacists, and nurses here 24 hours a day. We usually round from 7 a.m. to 7 p.m., and then the alternate side of the clock is taken over by another team, 7 p.m. to 7 a.m. So there's really quite a lot of overlap. There's constant rounding. There's rounding in the middle of the night. And any problem becomes apparent very, very quickly. And that's why there's such a tight ratio between provider to patient to notice any difference or any decompensation.
And I want to ask you both this next question, because I imagine it's so difficult seeing patients truly vulnerable. Their families are upset. There's a lot going on. How do you prepare for those challenging cases? And how do you you're both I don't use the word senior in an old way, but you're seasoned in this field. How do you help younger doctors and residents and nurses just starting out, kind of managing those emotions? Because I'm sure it's up and down, even as a doctor, and you're focused on cases. How do you manage all of that?
Families are and everybody's different. Everybody. You just don't know. People express anger and upsetness in different ways. So my suggestion is you have to always just keep your calm, introduce yourself, try to work on gaining their trust. That's really the most important, because once you gain their trust, you can subside all that anger and against you, and then help them understand what's going on with their loved one, and then in layman terms, describe to them what's going on and the prognosis. So I think the more that you speak with them, and the more that you show them, even though it's like a CAT scan that they probably have never seen before because they're not medical, it does help
Yeah.
because if you have a CAT scan of let's say the brain and they have a huge bleed, there's a different shade, right? So we can show that and say this is not normal, and that gives them reassurance, builds trust, and then together they can make a decision of where we're going to go with the care for the patient.
Well, Dr. Gray?
Yeah, very little to argue with there. I agree. It's mostly it's a process of education, really.
Yeah.
You educate first, of course, yourself and the team, and the education then also transfers to the family, so they can understand what you're doing and what the problem is. So yeah, I think the constant communication and education is the real solution to that.
What would you both say your biggest accomplishments are?
Well, for me, it's anytime a life is saved. There's nothing more rewarding than that. I mean, it's why all those sleepless nights in medical school happened. It's the big payoff.
Yeah.
The saving of a life.
How about you?
I think just being born and raised in New Jersey, so I know the state pretty well. I knew about the healthcare, and obviously I knew more as I got into healthcare. Seeing where our ICUs were to where they are now, and really been the only system to have a standardized ICU service line, both operationally and clinically. It makes me so happy because I understand that the care of New Jersey citizens are in good hands. God forbid, are in the ICU at RWJBarnabas.
We've got your back, and we've got excellent physicians here all across the system, not just here at Cooperman Barnabas Medical Center, but we are lucky to have you both with us. So thank you so much for being here today. If you still have any questions, you can always leave them. We'll get them over to Dr. Gray and Dr. Rezai. And thank you again for being here today. I know you're very busy, so I appreciate you taking the time.
Thank you for having me.
So until next time, everyone, we'll see you later. Bye.
Bye.